Hi, everyone. My name is Courtney Kirkland. I am an infection preventionist at Memorial Hermann Southwest in Houston, Texas. My background is in epidemiology and biostatistics, but I've been working in infection prevention for the last 6.5 years. Today, I'm going to give you an overview of my poster, which is on the use of no-touch disinfection technology to prevent transmission of healthcare-associated Acinetobacter baumannii infections. To start off, I'll give you a brief overview of the organism of interest. So Acinetobacter baumannii is a clinically important pathogen. It's responsible for many different types of infections in patients, and it's known to have a really high increase of resistance for antibiotics. In 2013, the CDC listed Acinetobacter as a serious threat, and then that was promoted to urgent in 2019, considering the carbapenem resistance and the ease of transmission. This organism can live on surfaces for really long periods of time. So that's the main reason why it contributes to healthcare associated infections and potential clusters and outbreaks. This poster that I'm going to describe today gives you an overview of a cluster that we curtailed at our facility. We'll go through a special terminal discharge cleaning process that we hardwired. And then lastly, I'll go through a couple of updates about new technology used for cleaning, for enhanced cleaning. Okay, so to start off, this facility is a 543 bed facility. It's a level 4 trauma center and it's located in a very diverse community. Although we didn't have any types of healthcare acquired or any type of transmission of Acinetobacter, we did have really high rates and really high numbers of Acinetobacter infections within the hospital just because it was in our community. Most of our cases were housed in the medical ICU, and before this cluster occurred, we did not do anything special with these patients. So they were not placed under any type of contact precautions or isolation precautions, and we did not have any type of special cleaning process for them either. So the next step will go over the cluster description. So following an alert from the ID pharmacist, infection prevention initiated an outbreak response to look at all of the Acinetobacter cases within the last month. The infectious disease pharmacist notified us of an increase, and so we followed up to do a retrospective look at the cases. If you look here at table 1, you'll see a table of the organism type and unit type by count. You can see that in the investigation that infection prevention initiated, there were over 13 Acinetobacter cultures within the last month. 9 of those cases were Acinetobacter baumannii. 7 of those were the multi-drug resistant Acinetobacter baumannii. 6 of those were considered to be healthcare associated, which are cases that were identified on day 3 or afterwards and had no indication or history of Acinetobacter before the encounter. And then lastly, there were over 7 units that were affected, meaning that the patients were dispersed over 7 units and pods within the facility. If you look here at figure 1, you'll see the epi curve for the cases. Starting with December week 1, we had a total of 4 cases, which were within 2 different areas. And then in week 3, we had 3 cases, which was all in one particular pod. So this shows the different types of cases that we saw in the cases of interest, which were the multi-drug resistant Acinetobacter baumannii cases. And those are the ones that are highlighted on the epi curve. Okay, so because of that, infection prevention assembled a multidisciplinary team to combat the cluster. The control plan was focused upon the terminal cleaning for the room. We thought that we would add a secondary no-touch disinfection step. For this particular intervention, the no-touch step was the electrostatic sprayer, which was done by the EVS team. The control plan also consisted of education provided to staff members, and all shared equipment between patients were cleaned with a bleach product. After implementation of this intervention, we did not see any additional cases in our surveillance period, which is highlighted in our epi curve here in figure 1. So you can see after week 3, we did not see any additional cases, which meant that our intervention was successful. So understanding that we did have a high burden of Acinetobacter in our community, and we expect some of those cases to be admitted to our facility, we decided to hardwire this special cleaning process to ensure that we could limit any future transmission and any other cluster or outbreak from occurring of the Acinetobacter baumannii. We were able to do that by using our infection prevention surveillance software to run reports on any patient with a history of the multi-drug resistant Acinetobacter baumannii and any patient with a new infection of that organism. The report allowed us to easily identify the room number the patient was in and, in fact, if it was an old or new infection. With that information, infection prevention created an email template that was sent out each morning to our multidisciplinary team. Over here in figure 3, it goes over or gives an example of the actual email that's sent out. As you can see here, we have a table that lists the different cases. We have Mr. Salmonella in Unit 1, and we have Miss Listeria in Unit 2. If you look at Listeria, you'll see that it's highlighted, which means that there's some type of change or an indication that this may be new. So it draws more attention to those patients. I also want to call out special stop sign that we have here in red. This is a symbol that is placed on a piece of paper, which is used as signage. It's placed on the patient's door, and it highlights to EVS that that room deserves or qualifies for a special cleaning, which again is the terminal discharge cleaning plus the secondary no-touch disinfection of the electrostatic sprayer. In addition, if you look at figure 2, you'll see the roles and responsibilities for the multidisciplinary team. It ranges from the floor nurses to bed management, EVS, clinical leaders, and quality, as well as infection prevention. Most of this goes to what we're supposed to do, which pertains to the education that is given to the healthcare provider and also the patient, and overall awareness. What we learned was communication was key, and understanding where these patients were in real time was very important to be able to curtail any other outbreak or transmission from occurring. I also want to call out the fact that bed management is a part of our multidisciplinary team, as they were with the intervention. They're important to call out because they're able to block or hold the room so that EVS is able to go in to do the terminal clean and the secondary no-touch disinfection. So with that, I just want to give you a brief overview of everything. This poster describes a highly successful intervention that was used to terminate multi-drug resistant Acinetobacter baumannii cluster. This intervention was very successful. We saw a decrease in the overall transmission of Acinetobacter, as well as an increase with our overall hand hygiene compliance and with an overall awareness of HAIs within our facility. We tailored this intervention based on the fact that our organism or that organism can live in the environment for a very long time and very hard to clean. So the use of the electrostatic sprayer was crucial so that we could get to those really hard to clean places or places that were cleaning properly or may have been missed during the standard terminal discharge cleaning. I also need to note too, if the patient went to another room or was transferred throughout the facility, that patient's old room also received the discharge cleaning plus the electrostatic spray. This special cleaning process is very labor intensive, and it takes a lot of different focus from many different departments, but it's proved to be very beneficial and successful. Over the last 10 years, we have been successful in minimizing any outbreaks or clusters associated to this pathogen because of this cleaning process that we hardwired. We also shifted our culture at our facility and our cleaning practices to be a distinguished level in terms of awareness on what to do whenever we do see a special stop sign or when a case is identified as such. In the end, having continuous surveillance, using basic infection control measures, using enhanced cleaning procedures are essential to curtailing or stopping any outbreak that may be occurring, and also to prevent spread of concerning pathogens. We have adopted this program to include other concerning pathogens such as the carbapenemase, enterobacterales, and Candida auris. Our next steps with this program is to look at other types of new sporicidal products, colorized disinfectants, or other no-touch disinfectant technologies such as the UV light machines or continuously active disinfectants to ensure that we're doing the best that we can to curtail any outbreaks from occurring. Again, my name is Courtney Kirkland with Memorial Hermann. If you guys have any questions, feel free to email me at the email address. Thank you.